There are still lots of myths about buprenorphine, and they continue to shape the way we care for patients, often without us realizing it. As clinicians, it's our responsibility to look closely at the evidence and make sure myths and stigma aren't getting in the way of life-saving care. One myth we hear a lot is that prescribing buprenorphine will just lead to diversion, with an underlying assumption that diversion is automatically harmful. But let's take a closer look at what's actually happening. Some buprenorphine is diverted, but it's usually to manage withdrawal or to stay off of riskier opioids, not to get high. In a 2016 study, only a third of drug users reported using diverted buprenorphine at all. And of those who did, only 12% said they used it to get high. The majority used it to self-manage their addiction. Further, a 2023 model suggested that more diversion could reduce fatal overdoses by replacing more dangerous opioids like fentanyl. So what should we take away from this as prescribers? Diversion doesn't necessarily cause harm, and it usually indicates unmet needs, not misuse. It's also important to remember buprenorphine has a ceiling effect that prevents respiratory depression. We also know what's in it and how potent it is. For both of these reasons, whether it's diverted or not, buprenorphine reduces risk of overdose. Another common myth: you can't prescribe buprenorphine unless your patient is abstinent from other drugs or has counseling. The data says otherwise. While follow-up care is important, buprenorphine is proven to work even without abstinence or mandatory counseling. Low-barrier programs that don't require patients to stop all substance use achieve strong retention and lower overdose rates. A Yale study found that medication-only programs outperform abstinence-only approaches. Treatment with buprenorphine reduced fatal overdoses, while abstinence-based programs showed no significant reduction in deaths. While recovery may mean intensive counseling and total abstinence for some people, others may continue to use substances or prefer a medication-only treatment plan. The evidence is clear: buprenorphine reduces overdose deaths. An especially harmful myth is that buprenorphine is just a crutch, and that those who use it are just trading one addiction for another. That is not true. Buprenorphine is evidence-based medical treatment for a chronic disease, not unlike insulin for diabetes. Opioid use disorder is a chronic, relapsing medical condition, but it is treatable. Buprenorphine reduces cravings and blocks euphoric effects of other opioids. When taken as prescribed, it stabilizes brain chemistry, reduces overdose risk, and helps people rebuild their lives. You may be wondering, what about 12-step programs? While some communities have been hesitant about medications like buprenorphine in the past, many have now taken a neutral stance to avoid further stigmatizing people. And it's important that we, in the medical community, don't reinforce the stigma that medication for opioid use disorder is cheating or not real recovery. What matters is that patients get the support that makes sense for them, because that's what works. Maybe people will be on buprenorphine the rest of their lives, and that's okay. Another myth that lingers is that you need a special license to prescribe buprenorphine. Fortunately, that's no longer true. The X waiver was eliminated in 2023, so there's no special license, waiver, or patient limit. The only residual requirement is a one-time, 8-hour training on treating substance use disorders when you renew your DEA registration. So even if you've never prescribed it before, if you're DEA registered and your scope includes Schedule III medications, you can start prescribing buprenorphine today and start saving lives. And finally, a myth that continues to do real harm: that people who use drugs don't actually want to stop. Most people do, in fact, want to make a change. A 2023 Washington State survey found that 68% of people who had used opioids in the past week were interested in reducing or stopping their opioid use. That's the majority, even among those not in treatment. So what's stopping them? It's not a matter of motivation, but stigma, fear, and lack of access. So here's what we can do. Stop assuming patients aren't ready. Offer help without judgment, whether that's naloxone, medication, or other low-barrier options. And make sure your emergency department or clinical site normalizes the use and initiation of buprenorphine. Thanks for taking the time to listen. Every conversation, prescription, and offer of care makes a difference. Together, we can change how opioid use disorder is treated.